a talk at the Internal Medicine conference. But it's a massive issue in the UK where I practice, and of course in the United States and many other countries. And although it hasn't thankfully become a major issue as yet in Pakistan, I think there's every indication that in future years it's going to be so. So what I wanted to do in my talk is to run through some of the ways that medical errors occur and lead to litigation, to give some illustrative examples, predominantly from neurological instances, patients appearing in the acute medicine unit, and then to give some thoughts as to how we might avoid becoming involved in medical negligence litigation in our own practice in the future. And I should say that I spend quite a lot of my time advising the defendants' medical teams in cases of medical negligence brought against physicians in the UK. Page 2.
Just press this and use down key.
Okay, so some figures and facts from the UK, and these are quite shocking figures, I think. And this is the year where we have the latest information of the costs of medical litigation in the UK. And you can see that the annual cost last year was £2.4 billion, and the pound at the moment, the UK pound, is about 1.2, 1.3 US dollars. So that gives you an indication of the kind of figures that we're thinking of. And because these cases sit around for some years before they come to fruition through the legal process, the NHS in the UK has to have a sort of a fighting fund to pay for claims that are likely to arise in the future. And that fighting fund is 128.6 billion pounds at the present time. And that's more or less the same as the annual budget for the British National Health Service. So it's a really big issue in terms of the cost to the healthcare system in the UK, and it may well become so in this country as well. Of course, our colleagues in obstetrics are liable for most of the costs of medical litigation, but a significant amount involves ourselves, the physicians, those of us who work in acute medicine. So some slightly old figures, but it hasn't changed. The percentages haven't changed, only the total amounts. And what this shows is that when litigation is successful and patients' claims are agreed by the courts, about 2/3 of the amount goes to the claimants. A relatively small amount is involved in payment of the legal costs of the defendants, and a whacking almost third is the legal costs of the claimant. So it's big business. It's good business for the lawyers who are involved on the claimant side in medical litigation. So it's not an issue in Pakistan at present, but I think that we do have a tip of the iceberg situation, and it is going to become a problem, an issue in due course. And there are many reasons for this. Patients' perception of us as doctors and our actions of doctors are changing, and they're far more liable to be critical of our management of their problems than was the case in earlier years. there's tremendous media and even more social media adverse comment on medical management and medical care, and the bigger medical legal cases are very much highlighted. So there's a lot of adverse comment in the press against doctors and the way that we deal with our patients. We've gone into a compensation culture, haven't we? And people think if something goes wrong, there must have been an error, someone must have been at fault, and they often think about whether or not this is something that can be litigated. And there are lots of lawyers in our society, and medical malpractice is a very lucrative growth area for the lawyers. So there are a number of factors that one often sees in cases of medical negligence that go through the legal system, where I've observed them in giving advice to the defendant's legal support. And these are all failures that shouldn't happen, but they commonly do happen. So failure to make good notes, to take a good history, make a proper examination, etc., etc. To come to the right diagnosis, failure to manage the patient correctly after the diagnosis, failure to follow guidance, written accepted guidance. If we don't follow that, then we're potentially in difficulty. Not supervising our juniors adequately, and a failure of communication with the patient and their family. So some would say that, well, the way to avoid the potential for medical negligence litigation against us is to practice defensive medicine, but I don't think that's the answer, and it's not a good medical practice to over-investigate, to refer patients unnecessarily, to keep on bringing them back for follow-up because we're unsure of what the situation is, etc. So defensive medicine isn't the answer. To a large part, the answer is enshrined in good medical practice that we all endeavor to fulfill in every day in our clinical practice. And an essential part of this is the doctor-patient relationship, whereby we should always treat our patients in a dignified way, respectfully, be honest with them, to listen to their worries and their problems, to inform them, to respond to their concerns. If there is a problem, if there is an error that occurs in the medical care, then we owe the patient a duty of candor, and we must be open and honest in the way that we deal with this issue for the patient. It never does any harm to apologize if there has been an error on our part, and in many cases that will leave the patient and their family happy, and they won't feel they have to have recourse elsewhere for satisfaction. So the kinds of things where we see it going wrong, the lawyers will say in the medical legal situation, no notes means no defense, and good notes means good defense. So I want to emphasize, particularly perhaps to our junior colleagues, the importance of every time there's an interaction with a patient, making good and comprehensive records, and bearing in mind the possibility that those records could be the subject of the intensive scrutiny in a medical legal situation at a later stage. Osler said, didn't he, famously, that listen to your patient and he'll tell you the diagnosis. So the history and the examination are still so important in our interactions with the patient. It's the beginning of our doctor-patient relationship, and it hasn't been overtaken by investigation. So in many cases where I've seen litigation take place, the fundamental problem has been that the first doctors who've seen the patient haven't made a proper history or made a proper examination. It goes without saying that we should work in systems with good administration, and that isn't always the case. And here's an example of a young woman who had presented with muscle weakness. It was thought to be a functional chronic fatigue syndrome, but amongst her tests that were done was an acetylcholine receptor antibody test. The result was filed away without being seen by the clinician, and some months later the patient deteriorated with their myasthenia and was severely ill on the intensive care unit for some weeks. Litigation follows. So good administration is very important. The most common errors that we see in litigated cases in acute medicine, by far the most common is the failure to make a correct or delay in diagnosis, and leading on from this, missing the appropriate treatment. Along with that, if doctors manage a patient without following the accepted guidance of that particular condition, then they're potentially walking into a dangerous situation, not just for the patient, but for themselves if there's a problem afterwards and litigation follows. Medication error is very common, and procedures may go wrong. So there are some features that we see in the way that diagnostic errors come about, and I needn't go through this in detail, but what we see is that once a diagnosis has been made, it tends to stick. So if the first doctor who sees the patient in the acute medical unit comes to a particular conclusion, not necessarily based on the right assessments, that diagnosis gathers momentum when the patient is considered by subsequent doctors, and the wrong diagnosis tends to stick. So here's an example of a man who had hypertension and migraine, who was admitted with the sudden onset of a headache that was similar to his migraine, but it was very acute in onset and the worst ever episode he'd had. He had a CT brain scan, which was normal, and was discharged with a diagnosis of migraine. And then a week later, he had the big bleed after that initial sentinel bleed that was not diagnosed, and came in a poorly way, was treated adequately, but had significant residual disability. So the lessons from that case perhaps would be that in the emergency department, the acute medical unit, migraine is a diagnosis of exclusion, very much so, and that a negative CT scan does not exclude subarachnoid hemorrhage. Just to further make that point, this was quite an old study now, but it showed that in patients presenting with subarachnoid hemorrhage in a grade 1 good clinical state, who had the correct diagnosis at the outset, over 90% had a good outcome, whereas in those in whom there was an initial misdiagnosis, over a third have a poor outcome or even a fatal outcome. So a few more examples just to briefly mention. I've seen a number of cases where patients have presented with herpes simplex encephalitis, and the diagnosis has been delayed, the treatment's been delayed, and as you know, even a 2 or 3 day delay in starting antiviral therapy may be significant in increasing the potential for disability. And so these cases will go to litigation in the UK. delay in diagnosis of autoimmune encephalitis. Again, I apologize for the neurological instances that I'm quoting, but they're the cases that I tend to have been involved with. Missing cord compression, misdiagnosing it as other conditions, missing the initial presentations of cerebral tumor are common in acute medical practice. So here's another example where the doctors came to the wrong conclusion because they didn't follow they didn't look properly at what they were seeing and follow the right guidance. So here's a man who was admitted in a confused state, unable to give a good history, but he had headache, he was mildly pyrexial, he had neck stiffness, and his white cell count was elevated at 17. So the doctors felt that this was likely to be meningitis and proceeded to a lumbar puncture. The CSF was heavily blood-stained, the pressure was very high, the patient coned and did not do well after this. We know that the guidance that we should follow in adults presenting with suspected bacterial meningitis is that a CT head scan should be undertaken if there are any of these features, including an abnormal level of consciousness, which that patient had, and focal neurological deficit, which the patient had. So guidance was ignored, the wrong decision was made, the outcome was poor. In stroke medicine, there are increasing numbers of litigated cases where the management has not followed the accepted guidance. So in thrombolysis in stroke, we see a lot of cases coming to litigation where the patient has not been thrombolyzed within that 4.5-hour window of opportunity. And we know from the papers published in the Lancet and elsewhere that if we give thrombolysis in that time window, there is a reasonable expectation of a better outcome. And if the patients have relatively minor disability at their presentation, then that likelihood of a good outcome is greater than 50%. Similarly, with the use of aspirin in patients that present to us with a transient ischemic attack, we know from the literature that there's about a 25% chance of avoiding secondary serious vascular events if we give aspirin soon after the TIA. And we know that that improved outcome is greater than 50% if the patient is given aspirin within 24 hours of the TIA. So these are instances where patients present with these problems, the guidance is not followed in the management, and the outcome is not good, the patient sues. Performance of procedures, we need to make sure that we are properly skilled and trained in undertaking the procedures. Here was a poor chap who was admitted with what turned out to be a benign viral meningitis. The doctors in the acute medical unit tried on 11 occasions to lumbar puncture the patient, and it was only on the 12th attempt that the consultant anaesthetist who was brought in was able to do it. That patient had severe back pain after this procedure, and that became chronic, and he was unable to work and sued. Here was a patient on the ITU where the doctor went to put in a central venous line into the jugular vein. Unfortunately, it went into the common carotid artery, dislodged a thrombus, and the patient had a stroke. So again, in all these cases, litigation follows. The cost of medication errors is high and is increasing. And an estimate in the paper in the BMJ in 2020 was that there are 237 million medication errors in England annually, and in a quarter of those, it's a clinically significant issue. One of the huge multi-case group litigation that's starting up in the UK at the moment is in children who have had cognitive impairment as a result of exposure in utero to when the mother has been given valproate during the pregnancy. And this is against the guidance that we've been using for many, many years, but lots of patients have been treated in that way, and the cases are going to be very costly. So the impact of medical negligence litigation, the average claim takes 3 years to come out of the woodwork, and then usually takes many years going through the legal process until closure. And this is an incredibly stressful period for the patients and their family, and of course it's extremely stressful for doctors as well. And on occasions, doctors have committed suicide because of the stress of ongoing litigation. So there should be a better way of dealing with this, but without involving the expenses that we have at the moment. But unfortunately, we haven't developed those better methods as yet. So I'm sure each of you here, your practice is to a highly satisfactory level, and you're confident that you're not going to be exposed to medical litigation, but it can happen to any of us, and the ways of avoiding it I've listed here, and I'd emphasize the importance of following guidelines, good communication, good team working, and lastly, not criticizing patients in a situation where, criticizing colleagues in a situation where something has gone wrong. So, ladies and gentlemen, I hope that you're never in court hearing the judge's gavel go down on a case that you've been involved with. Thank you for listening.
Thank you, Peter. I think in interest of time, I'll just ask my colleague, Dr. Aziz, to say a few words, and then we'll close the session. He's from Healthcare Commission, Peter, so he's the gentleman who deals with the claim.